Hey, welcome back to Not So Complicated, and today we'll be talking about Global Initiative for Asthma, that is GINA guidelines, the updates of 2025 comparatively to the 2024, right? So let's talk about that first. And in parameters, there is treatment strategy, right? Track 1, track 2. Track 1 is preferred strategy, and then in track 2 there is step 4. In GINA 2024 for treatment strategy of adults and adolescents, there was medium to high dose inhaled corticosteroids and long acting beta agonists, right? And then that is revised to only medium dose, not high dose, only medium dose of ICS lava in 2025. So that is one of the differences. And flutic acid furoate doses, these were grouped differently in 2024, but in 2025 it is like low to medium doses, that is 100 microgram to, and then medium to high doses, that is 200 microgram. And in high dose ICS, that is inhaled corticosteroids, again it was allowed as needed in 2024, but it is not like that in 25. That is limited use to 3 to 6 months if possible, right? And phenytoterol is another drug, and it was not specifically mentioned in 24, but it is now not used due to cardiovascular risk in 2025, right? So these are one of the table for treatment strategy of adults and adolescents. And in treatment strategy, like diagnosis and management of children under or equal to 5 years of world, so there are certain changes in this too. So the parameters are asthma diagnosis first. In 2024 there was unclear stance, right? But in 2025 there is three steps pragmatic criteria. That is, one is recurrent wheeze plus interval symptoms are there, and the another one is exclusion of alternative diagnosis, and the third one is response to inhaled corticosteroids plus or minus, like present with or without SAVA, that is short acting beta agonist. So this is the pragmatic criteria for 20 like diagnosis of asthma in children under 5 years of world in 2025, unlike 2024, right? So, and also exacerbation treatment is that like nebulized and intravenous magnesium used to be used in 2024, but it is not that in 25. That is nebulized magnesium is removed in 25, and in oxygen targets, talking about oxygen targets, 94, like greater than 94 percentage to remember, like that. In 94 to 90 94 to 98 percentage of oxygen saturation were target for 2024, but greater than or equal to 94 percentage with adjustments to skin color and altitude is for 2025 in children. And in adults, 93 to 95 percentage of oxygen saturation is preferable in asthmatic patients, right? So let's talk about asthma treatment steps in adults and adolescents first, right? So this is how we do at first, that is assess, adjust and review. So assessment is done for the confirmation of diagnosis if necessary, and symptom control and modifiable risk factors, comorbidities, inhaler technique and adherence, and patient and parent or caregiver preferences and goals, right? So that is how we assess the condition. Then we adjust if the findings of assessed conditions are not ideal, then we adjust the assessment, right? So we do the treatment of modifiable risk factors and comorbidities, non pharmacological strategies, asthma medications including ICS, education and skills training, action plan. And then we review the symptoms, exacerbations, side effects, comorbidities, lung function, consider biomarkers, patient and parent or caregiver satisfaction. So that is how it all goes. So let's talk about this tracks at first. The track 1 is preferred controller and reliever, using ICS formoterol as the reliever, reduces the risk of exacerbations compared with using a SAVA reliever, and is a simpler regimen, right? So this is how the track 1 works actually. So we all know that it is a step up and step down approach, right? So the first step 1 and 2 for preferred controller and reliever track 1 is that air only, low dose ICS formoterol is needed. Air is, what is air? You have to understand that air is anti-inflammatory reliever, right? So anti-inflammatory reliever only, and low dose ICS formoterol is needed, should be done in step 1 to 2, right? And in step 3 there is MART. What is MART? MART is maintenance and reliever therapy with low dose maintenance ICS formoterol, right? And in step 4, MART with medium dose maintenance ICS to formoterol. In step 3, it was low dose maintenance. In step 4, it is medium dose maintenance. And in step 5, we have to add on long acting muscarinic antagonist, right? So we also have to refer for assessment of phenotype. And phenotyping of asthma is done by various ways, but in 2025 there is one parameter that is added in appendix A, that is type 2 biomarkers. We'll be talking about that in last slide, right? So this is the step up approach actually. So it is based on symptoms. So if the symptoms are milder, that is steps 1 to 2, and if the symptoms get worsened, then we have to up the steps to 3, 4, and 5, right? And after stepping up to step 5, then we assess the condition of the patient, and if the condition of the patient is getting relieved, right, and if it is not an emergent condition, so we step down. That is the strategy actually, and we use reliever as needed low dose ICS formoterol, and that is how it works, right? And another track is track 2, which is alternative controller and reliever. So first track is preferred over this track because you have to use only one what do you say, inhaler, right? One inhaler, and the patient is very compliant on that, right? So the step 1 is reliever only. If SABA, take ICS with each dose. And step 2 here is low dose maintenance ICS. Step 3 is low dose maintenance ICS LAVA. Step 4 is medium dose maintenance ICS LAVA. And step 5 is add-on LAMA again, right? Refer for assessment of phenotype, consider trial of high dose maintenance ICS LAVA, and consider anti-IgE, that is immunoglobulin E, and anti-interleukin 5-5R, anti-interleukin 4-RA, and anti-TSLP, that is thymic stromal lymphopoietin, if you don't know about that, right? And then reliever here, sorry. So reliever here is as needed ICS to SAVA or as needed SAVA only. So ICS and SAVA can be used together, or if it is needed, you can use SAVA only too. So in asthma treatment steps in children of age 6 to 11, talking about that, raw assessment, adjust, and reviewing, all of them are same, almost same, right? And then we do preferred controller to prevent exacerbations and control symptoms, right? Other controller options can be there too. So step 1 is you have to use low dose ICS taken whenever SAVA is taken. So SAVA only is not preferred in children. So that is the new update. So you don't have to use, you cannot use SAVA alone with ICS, right? So yeah. So low dose ICS taken whenever SAVA taken. And then step 2 is daily low dose inhaled corticosteroids, ICS, set table of ICS dose ranges for children, and daily leukotriene receptor antagonist, that is LTRA, or low dose ICS taken whenever SAVA is taken, right? So leukotriene receptor antagonists are like zafirlukast and montelukast, right? And step 3 is low dose ICS LAVA, or medium dose ICS, or very low dose ICS to formoterol maintenance and reliever, that is MART. And again, low dose ICS plus LTRA. These are for other controller options, right? This is not primary controller options, the lower slides. These are not primarily, or less evidence for efficacy or safety kind of thing. And then these are like step 4, medium dose ICS LAVA, or low dose ICS formoterol MART, or you can refer for expert advice, add tiotropium, or add LTRA, again that is leukotriene receptor antagonist. And step 5 is that you have to refer for phenotypic assessment with or without higher dose ICS LAVA or add-on therapy, right? And then only as last resort, consider add-on low dose OCS, but consider side effects. So this is the step up and step down approach for children of age 6 to 11. Reliever is as needed SAVA or ICS formoterol reliever in MART in steps 3 and 4. So talking about children of less than 5 years of age, the assessment, adjustment, and reviewing is the same procedure. And okay, so it is the children of less than 5 years of age. So that is a mistake right there in above, right? So this is for children less than 5 years of age. So asthma medication options, adjust treatment up and down for individual child's needs. Obviously, we have been doing that in all of the patient conditions. And preferred controller choice here is like step 1, insufficient evidence for daily controller. That is step 1. Consider intermittent short course ICS at onset of viral illnesses. That is other controller options. That is not preferred. That is other controller options, because that is not preferred because of limited indications or less evidence for efficacy or safety, right? So in step 1, there is insufficient evidence. And in step 2, daily low dose inhaled corticosteroid can be used, or daily leukotriene receptor antagonist, or intermittent short course of ICS at onset of respiratory illnesses can be used. And in step 3, double low dose ICS, consider specialist referral. And then step 4, continue controller and refer for specialist assessment. So that is how you do step up and step down, right? And the reliever is needed short acting beta 2 agonist. So to consider this step, there is another step to be considered with, like for children with infrequent acute wheezing episodes, that is due to viral induced maybe, and no or minimal interval asthma symptoms, right? So asthma symptoms not well controlled, or one or more severe exacerbations in the past year. So these steps are considered for only those children who have infrequent acute wheezing episodes. You have to remember that. And asthma not well controlled on low dose ICS, asthma not well controlled on double ICS. So before stepping up, we have to check for alternative diagnosis and inhaler skills, review adherence and exposures, right? So that is all. And then we have to do the like choice of inhalers. How do we choose the inhalers for different patients? So for this patient, you have to ask yourself, for this patient, which is the right class of medication? So we have to consider exacerbation, risk reduction, symptom control, and adverse effects. If different reliever and controllable inhalers are needed, we have to consider questions below for both. What are these questions? These questions are, there are 4 questions actually. So you have to, like for these medications, which inhalers are currently available to the patient? Which of these inhalers can the patient use correctly after training? Which of these inhalers has the lowest environmental impact? And follow up, that is the patient satisfied with the medications or inhalers? So that is the last question that is done in follow-up episodes, like if the patient comes after the treatment, right? So optimal inhaler selection is done via these questions actually. So that is the choice of inhalers. And this is a new portion in 2025, that is impact of extreme weather and temperature. It was not included in 2024. So basically extreme weather like heat, cold, rain, floods, storms, drought, dust, landscape fires, these are considered in asthmatic patients, impact on infrastructure and disruption to medical care, and direct health effects on people with asthma, like heat waves increase the risk of asthma emergency department ED visits by 7 to 34% for about 1 week, right? So that is the impact of heat waves. This was not included in 2024 guideline actually. And cold spells increase risk of ED visits by ED is emergency department, that is by 20%. Lag effect is there, and some evidence for increased asthma mortality is there. And also thunderstorm asthma can be present, like epidemics of asthma exacerbations associated with grass pollen or fungi, right? And mitigation strategies for these are very limited evidence, that is face masks reduce PM 2.5 exposure, and shelter in temperature controlled environments, example shopping malls, and also mobile phone alerts to prompt behavior change, right? And this is the appendix I was talking about on type 2 biomarkers for phenotyping. So there are different clinical utility for this, right? So the factors affecting blood eosinophils, and then pheno, that is what we will be talking about. That is what is included in this, right? So the clinical utility of type 2 biomarkers is that diagnosis of asthma, phenotyping of asthma, and prognosis for risk of exacerbations, selecting asthma treatment or predicting response, mild, moderate, and severe asthma, right? So this is the appendix that was added. Blood eosinophil count and fractional exhaled nitric oxide. So these are 2 different things, right? So there are typical criteria for high in adults or adolescents. So you can look at that yourself. I'm not going to explain that, right? So that is all about 2025 GINA guidelines. So thank you. Please subscribe for more, and I hope this helped you. And if you have any questions and queries about this, you can comment it down, right? You can comment down. So thank you.